that's not really in your training. So that's how it is for our county though. We have, diagnosis centered protocol for respiratory distress. So it is what it is, so we'll deal with it. So with that in mind, I've kind of broken down the lecture into some of those categories that we see in our protocol. So briefly, and all of these are going to be discussed in the format of an actual case, okay? We'll start with COPD. We'll also discuss congestive heart failure and pulmonary edema. We'll talk a little bit about pneumonia and asthma, and then near the end, we'll have more of a discussion about CPAP, how it works, why we use it, and some contraindications. And then at the very end, I do have the run review that I mentioned previously from last month. So the first patient we have is a 68-year-old female. She presents, she tells you she's had shortness of breath now for 2 or 3 days. She's had a little bit of a dry cough, really hasn't had any sputum production, doesn't think she's had any fevers. She does smoke. You walk into the mobile home and you can smell the cigarettes. You kind of know can kind of set the picture there. And she's still using her oxygen though when she smokes, so that's always a good thing. And she's usually on 2 liters, she says, around the clock, 24/7. So what are you guys thinking about this lady? Yeah, exactly. Okay. So you get a set of vital signs. She's pretty normotensive. She's tachycardic though. Respiratory rate, she's 25, so she's somewhat tachypnic. Satting 85% on her usual 2 liters. So, and she's obviously in some distress. She's sitting on the edge of her bed, kind of sitting forward, tripoding. She can only tell you in 2 to 3 word sentences that she was short of breath and that she still smokes. When you go ahead and listen to her lung sounds, she has very distant breath sounds bilaterally, and you check your stethoscope to make sure that it's the right way and that it's working, and it is, because you really can't hear any sound. And she's got little tiny chicken legs. You guys got the picture, right? Okay. Brad, I think is it up there?
Yeah.
Okay. This is not the computer. Okay.
If it doesn't work, I'll be your.
Good to know. Okay. So what are you gonna do for this lady? Okay. Good job. Good deal. I like that. What else? Huh?
Cigarette out, yeah.
Cigarette out, good. Probably put the cigarette out before you put her on oxygen, right?
See if she improves with oxygen, and then think about albuterol.
Good, absolutely. Definitely, yeah. I like those. So definitely albuterol for this lady. And definitely I think this is someone who you can think about CPAP for, okay? Especially if she doesn't really come up much on, increasing oxygen, if the nasal cannula is not enough for her. And, even if her stats do come up on a non-rebreather, a lot of times the CPAP is going to be helpful, more helpful for her long term. And then also, probably, this is obviously someone who's pretty sick, so getting the saline walk started. She's been tachypnic for a while, you become dehydrated if you're tachypnic for a period of time, okay? So, and she's obviously pretty sick and is going to need other stuff when she gets to the ED. So, starting a saline lock, you'll be the ED nurse's best friend. All right, so I think we've all made the diagnosis on this one. Pretty straightforward. COPD exacerbation. More commonly in older patients, you have to have time for the cigarettes to catch up to you. Usually a past smoking history. A lot of times though, if they don't have a smoking history, but they've lived with a partner who's smoked, for long periods of time also. Sometimes you're going to see it with occupational history, like if there's a history of asbestosis or, that type of, occupation when they were involved with that, you're going to see COPD. You're typically going to hear very distant breath sounds, which is basically explains that you essentially hear nothing because you don't hear anything. and by history too. Okay, so she's on supplemental oxygen. She's got a history of COPD inhalers. So people know when they have COPD. And this right here is an X-ray. I tried to put up a couple X-rays so you guys can kind of get a better idea. I think sometimes pictures and X-rays are helpful to kind of further understand. So you see that the lung, like it seems like the lungs are really elongated, I guess is a good term. So this is a pretty classic X-ray for someone with COPD. And you see that there are not a lot of lung markings on there, and that's because basically the structure of the lungs have been deteriorated from that's kind of part of the disease process, and that's why you don't hear a lot of air movement, okay? And you get air trapping and that type of thing, okay? Okay, so the next patient we're going to talk about is a 75-year-old male. He had the sudden onset of shortness of breath and chest pain at 3 in the morning. It just woke him up. So you find him, well, let's talk about a little more of his history. So basically, he tells you that he's had lower extremity edema that seems to be, he also always has chronic lower extremity edema, but it's been a little bit worse over the last week or so. He hasn't had any fevers, but he has a productive cough. You ask him, kind of, has his sputum been yellow, green? He's like, well, it's just kind of been clear and whitish. Okay. So he is actually hypertensive. Okay, you check his the rest of his vital signs. He's tachycardic. You also notice that his heart rate is somewhat irregular. Okay. He's also tachypneic rather, and his room air stats also are 85%. He does not typically wear oxygen at home. Okay. He's also in a fairly significant amount of distress. He's also tripoding at the edge of his bed, where he woke up with his chest pain and shortness of breath, only speaking in 2 to 3 word sentences. Now, when you listen to him, actually, you don't even need to take out your stethoscope. You walk into his bedroom, and you can hear him gurgling on his bed. Okay. And you look down, and his legs are the size of tree stumps. So what do you think about this guy? What are you going to do? Nitro? Okay. Anyone want to do a 12 lead?
Yes. And quiz him about his chest pain.
Yeah?
Increase with deep inspiration, those kind of questions.
Mm-hmm. Is that going to change whether or not you do a 12 lead?
No.
Okay. Good answer. Yeah. So yes, I agree. Do you guys want to give this guy albuterol though? No. Okay. Fair enough. I agree. So this guy, his history is fairly consistent with congestive heart failure. So you are correct. I do agree with the CPAP. Agree with the 12 lead. Aspirin obviously too, with the history of chest pain that he had. Saline lock, he's pretty sick too. Okay. You may want to give him. You may want to consult base to give him working at some point. You may not use the saline lock, but he's definitely going to need it when he gets to the hospital. Okay. And nitroglycerin. So these are my comments on nitroglycerin, and I think some of you guys have heard this before. Nitroglycerin certainly is very helpful, and that's one of our mainstays of treatment with congestive heart failure. And in someone who is hypertensive like this guy, his blood pressure is 180 over 110, quite appropriate, and it certainly is in the respiratory distress protocol. If this guy's blood pressure was 120, 130, or lower than that, I would think a little bit more cautiously about giving nitroglycerin. And this is the reason why. And this guy, again, is pretty straightforward, but let's say the guy felt warm, okay? Does he have pneumonia causing his current respiratory distress? If he's got pneumonia and is septic, and you give him nitroglycerin, his pressure may be fine when you guys see him, 120, 130. You're going to give him nitroglycerin, his pressure is going to that's my only caveat for nitroglycerin. And yes, I know it's in the protocol, but you just have to think a little bit, just think twice before you go. Okay? I don't have a problem giving it, but just think twice.
What about if he was in an atrial fib, I don't remember the rate,
Yeah.
you worry about like an RDR and borderline blood pressure.
Absolutely, absolutely. And a lot of times when these guys, and sometimes that can be the etiology of low blood pressure, okay? So, and a lot of times what we'll do when they get to the hospitals, we'll give them something to slow their rate down, and it does help their blood pressure. Not always, but sometimes. Fortunately, most of these CHF guys, if it's just CHF and not compounded with something else, they are usually hypertensive, which is fortunate. But that's something to think about also with the AFib, and a lot of times they can be hypertensive because if their rate is faster than like 110 or 120, if they're in the 140s or 150s, a lot of times they're hypertensive just because of the AFib. Yeah.
Would you also, I don't know if this matters, but for someone who's typically hypertensive and who you think is in failure and now is maybe not so hypertensive, so that could be hypertensive for them, the use of the nitro spray versus transdermal, nitro paste, is that really a consideration?
That's a good question, and this is how I kind of think about that. Different people, so if you give sublingual nitro, it's more potent, and you're more likely to drop the pressure. I typically use the nitro paste initially, and this is for a couple of reasons. One is it's less work intensive. Okay, so if I've got a busy emergency department and I ask the nurses to give 3 sublingual nitroglycerins, 5 minutes apart, you've got to sit there, monitor the patient, take blood pressures every 5 minutes, and it's very time and work intensive. And this can be applied to you guys also. You're doing a lot of things by yourself in the back of the ambulance. You might have a very short transport time.
Really?
Like you pointed out earlier. Yeah. So, in this case, in spray, it's a little bit easier, but, for someone like this, just slap the paste on them. It's easier.
But for a QI standpoint, like, are they going to be looking at, like, why didn't you put a sublingual in before you did the transdermal?
That's more of a question.
I don't know. I wouldn't call either way.
That's our protocol.
I would say, yeah, I mean, the protocol says to give sublingual prior to using the paste, but if you have the patient that you're describing and you're going to call anyway about the use of nitro because this patient is possibly going in the hypotensive direction, then tell them that you're going to use the paste first and then they can concur and then you're fine.
So just write it down on the report as a base.
Yeah, just do, that you received orders and what they were. Received orders to use nitro paste.
You can always use
Yep.
Yeah, I mean that's the thing. You give them a sublingual, and ooh, the pressure that you need, you can't get that back. So
What?
nitro paste is just wipe off stuff.
Yeah, as a subcategory for, yeah.
What's your feeling about, between the spray and the tablets, about effectiveness?
I don't have a feeling because I never used a spray, not cheese, so can't answer that. Sorry, I can do some research on it for you. Yeah, we typically do sublingual. Yeah, Mike's. There you go. We typically do a sublingual paste or IV. So if this guy comes in with paste on, we put him on BiPAP. He's still really struggling after 10 or 15 minutes. You guys already put paste on. His pressure is still 180, hasn't touched it. I'll start this guy on nitro drip. Okay, so that's kind of where we go here. I don't see a ton of sublingual nitro used anymore, but that may just be me because I don't use it. Every practitioner in the ED has kind of got their preference for various reasons. But that's one reason for not giving sublingual nitro for much anymore. I give it sometimes, yeah. So yeah, for this guy, paste, and then that gives me a chance to say he's had it on 10 or 15 minutes by the time you guys bring him in and I see him and he's still super hypertensive and working. Even despite the CPAP and the paste, I'll switch him over to BiPAP and start on nitro drip. Okay, so just so you guys know how nitro works in this situation, it's a vasodilator. Okay, so it's going to help vasodilate this cardiac musculature. Okay, the heart doesn't have to work so hard. Okay. It's now the mainstay of therapy for someone with CHF, even over Lasix. Okay, you guys know we don't have Lasix in the policy anymore, right? Okay.
Can I just, like, I don't want this to go on tangent, but
No, it's okay.
a lot of people are afraid to, like, saline lock versus bag, and they say, oh, don't hang a bag because, you know, they're in failure and you don't want to fluid overload them. But I was always taught do a bag for a couple reasons. One, because you mentioned the respiratory distress cannot, you know, tachypnea causes some level of dehydration, and
Right.
probably a cup or less of fluid is not going to throw them into fluid overload.
Yeah, I think having a saline lock with a bag versus having a patient come in without any IV access is preferable. Okay, and a lot of you guys, because you guys usually do just like TKO.
Mm-hmm.
Yeah, that's very appropriate for this guy.
And it'll help you give your meds too. So.
Yeah, because you're gonna give some meds, maybe gonna need a little flush, and you know it's all set up. Very good questions.
Here.
Okay, next. So this patient obviously has CHF and pulmonary edema, which has come on pretty suddenly. So again, typically you're going to get older patients with a history of cardiac disease. Very frequently they're going to have a history of AFib or be in new onset AFib. Okay. And again, you know, they may or may not have a CHF history, but usually they do. And this is going to be kind of a classic CHF radiograph. You kind of see the bilateral fluffy appearance. Okay. It's typically what you're doing with CHF. So.
Down.
Don't forget to do a 12-lead. All right.
And put ETCO2 on.
And what?
And put ETCO2 on.
Yes.
And
Check website.
you're right.
The next revision of the lecture will probably have that N-channel CO2, but then it might be 3 hours long. So we might have to do a separate lecture on that. But definitely, I think N-channel CO2 is very helpful, and I don't focus on it as really in this lecture, but it's definitely a good resource. 70-year-old male, short of breath for 2 to 3 days. Just kind of has some generalized weakness. Doesn't really feel like he's on a bed much and doing much. Usually walks to the to the mailbox, gets a meal every day. Really didn't do it yesterday because he was just feeling too weak. He has had a productive cough. It's more colored, not really white and frothy. Definitely got some yellow sputum there. He's felt a little bit cold. His wife says he's been wrapped up in blankets all day. Has a history of hypertension and diabetes. Doesn't know what his blood sugar is running. Blood pressure is pretty normal, intensive, 130/80. He is tachycardic also. He's tachypnic. Room air sats 85%. I kind of tried to make these all kind of similar in some ways, so you kind of get the general subtle differences. Patient's tripoding, speaking 2 to 3 word sentences. So when you listen to him, so he's actually got wheezes and bronchi. Seems to be a little bit more on the right than the left. Doesn't have any real edema in his extremities, and he feels really warm too. Not sweaty, just hot and dry. What are you gonna do?
Oops, sorry.
So what do you guys think about this guy? What are your thoughts? Think he has CHF, pneumonia,
He's from Rome.
bronchitis? Okay. Yeah. Got a lot of flu going around, a lot of respiratory infections. So you want to give him albuterol? Do you want to CPAP him? What do you want to do? Good answer. Good answer. Okay. We'll go on to the next slide. So yeah, I mean, I think, so this question always comes up, and no one has asked it yet. Some of you might be thinking, I'm just going to put it out there and talk about it right now. So some concerns that have been brought up to me in the past is that there's this conception that we shouldn't be using CPAP on patients with pneumonia because it pushes the gun for the infection like deeper into their lungs or something like that, which is not the right way to think about it. So you should not be concerned. Someone who is hypoxic and has in respiratory distress and a good idea to use CPAP, okay? Because it helps open up, and we'll talk more about the details of how CPAP works. It helps open up the airways, it splints them open, and it's going to deliver better oxygen, and it significantly increases the distribution of albuterol in your nebulizer also, okay? That's the other thing. So, you know, if for nothing else, it's going to help your albuterol treatment, okay? It's going to help it be more effective, okay?
Would you say you just like start lower and stay lower, or
Yep.
have you seen it?
I always
evolve over time?
recommend, you know, start low and see how the patient's doing. You know, a lot of times they just need a little bit, and it kind of depends on how they're tolerating it. And I don't know if I have a slide about this later, but CPAP is, most of you guys know who use it. It takes some coaching sometimes. Okay, if someone's like really agitated, and kind of have to calm them down and say, hey, you know, this is going to help you. Just give it a few minutes. It takes a little bit of coaching too. Okay, and we do that with BiPAP also, because it can be a little bit claustrophobic when you strap a mask on to someone's face and they're got air hunger anyways, and so just be patient with it. Okay, if the patient wants to rip it off right away, just kind of step back and kind of explain to them why you're doing it and what it's going to do and how it's going to help, and retry it. And sometimes I'm not certain about your device. It straps around the head. Yeah. Okay. Sometimes just trying to not cinch it around their head, but if you just want to manually hold it to their face, you're still going to get some effect from it. So you can also try that too, instead of just trying to like cinch it down around their head.
So like coaching them first, get them to get comfortable.
Yeah, I mean if there's exactly. And kind of try to make them as comfortable as possible in other ways, like their sitting position. If they've got like chronic back pain, they need some just kind of some things to make them generally more comfortable first, and kind of tell them what you're going to be doing. You're going to be putting this mask on. It might feel like it's a little bit claustrophobic, but it's helping them deliver better oxygen and helping them medicine work better. Yeah, and not a lot of time.
I think over time we're seeing more patients now that have had it before.
Yeah.
And now they're used to it, and
Exactly.
it almost gives them some relief knowing that you're
Right, and a lot of people just knowing that they're getting extra oxygen for some reason, that helps people feel like
Sometimes they walk in and they're like, I need CPAP.
Yeah, exactly. So, and a lot of people have CPAP machines that they use at night, because we're seeing a lot of people with all these disease processes that are obese, and so they've got, obstructive sleep apnea, and they use CPAP at night. So these people are everyone's getting more familiar with CPAP and that type of thing. So, you're right. So this person has, anybody? Yeah, okay, good deal. So, pneumonia, you're going to get also more in older patients. More gradual onset, okay? Although, interestingly, I feel like the older the patient gets, they get ill pretty quickly, and it can be just all in a day's time. Hey, I got up this morning, I felt great yesterday, I got up this morning, I just didn't feel quite right, and then by 4 o'clock in the afternoon, they're in my ED's totally septic and hypotensive, and the temp of 103. So a lot of times they've got other comorbidities, they're diabetics, hypertensives. Think about pneumonia more if you only hear lung crackles or abnormal lung sounds on one side or the other, or one particular area. Doesn't matter if they've had the pneumonia or flu vaccine, and we're seeing a lot of people this year with very severe flu, and some of them have been vaccinated. Most have been unvaccinated, the ones that we get it, and are getting super imposed pneumonia. It's pretty severe, and even younger people. So good questions to ask though, and I know that we always do this as our screening tools in the emergency department. You have your pneumonia vaccine, this and that. Good questions to ask, but doesn't always, oh, well, they have the pneumonia vaccine, then it can't be pneumonia. Because pneumonia vaccine only basically is geared more towards like strep pneumo and those types of bacteria that are the more common causes of pneumonia. But as you guys, I'm sure, know, a million different bacteria can cause pneumonia. So, and a lot of folks, aspiration, if you're coming from like, Mission View or EG Care, they've got a pig tube and they aspirated and they got pneumonia. So, okay. All right. So, speaking of 70-year-old male who has been short of breath since last night. So day shift just came on and noticed that the patient is profoundly hypoxic and you can't get any other history basically because the patient's demented and can't give you history. Family is nowhere to be seen, and the day shift staff at the care facility just came on. Night shift's no longer there, and all they see is the patient's completely out of it and in respiratory distress. So this is what you got. And you know that this happens more than all right, next. Is it me or?
Try pointing it this way.
Okay.
On the computer.
Yeah. No, it's not you.
Okay. So you can't get a set of vital signs. Patient's blood pressure is 130/80, a little bit tachycardic, tachypneic, oxygen saturation is horrible. Patient's actually probably not tripoding. Patient's probably too weak to sit up out of bed, but should be tripoding if they kind of think to sit up out of bed. You know, only speaking 2 to 3 word sentences, and bronchi and rales bilaterally. Sounds wet, sounds junky, doesn't sound good. Next. So, what do you think about this person? What are you gonna do? Yeah, he's demented. Can't give you a history. So, except short of breath and you're
What
always
are the skin
skin.
signs?
Huh?
What are the skin signs?
Skin, maybe warm, maybe not. The patient's had 10 blankets put on, so you don't know for sure if he's
And the
warm.
heater's on.
And the heater's on, and it's January, so you don't know if he's warm because the staff has put a bunch of blankets on to try to help him feel better overnight, or if he's actually got a fever.
Any other signs that people
What was that?
do you have any other signs that people gave you?
His legs are like, not really chicken legs, they might have a little trace pedal edema. So this is intentionally kind of one of those borderline cases.
So is it aspiration?
It's more real life, and it's more akin to what
They weren't hypertensive, right?
his blood pressure is 130/80. So for now you're good.
The heart rate was 110.
110.
So, it wasn't sudden onset?
Well, you're not
Oh,
sure
we don't know, so.
because the day shift just came on. The day shift just came on,
Yeah.
and night shift's already gone. It's intentionally supposed to be a little.
You don't need to go.
So what do you want to do with this guy? What do you think?
Start with oxygen and then work your way up.
Oxygen? Okay.
Was CPAP if he's altered or more altered than his normal?
So he can tell you that he's short of breath. Very good question. So he can tell you that he's short of breath, and he's like awake and looking at you. But he's just like, doesn't know what the day is, and yeah. So I don't know what the day is either, but that's all good.
You might not tolerate the CPAP well either.
Right, right. So a little bit of coaching, especially if some of the more traumatic demented people, but he's pretty awake though. So he's awake,
Follows commands.
and follows commands, exactly. So he can be somewhat cooperative with you. Exactly. Are you gonna give this guy albuterol? No? Okay. Alright. What about nitro?
What was 0.9 miles away from you, I'm driving to you.
Yeah.
From a pre-hospital patient to a hospital patient, that's my priority.
Yeah. So
Yeah, I had that. What about 12?
I mean, you could make an argument for nitro on this guy. If you know I'm on, I probably wouldn't give him nitro though. He's just kind of like the nursing probe patient, more likely to have aspirated. You know, probably has a little concomitant CHF to go along with it. You're just not quite sure. I'd be like, CPAP, you know. And this guy, I think, you know, he's a little bit tachycardic, but I think albuterol might help him a little bit. Probably not going to hurt too much in this guy. Okay. I could try a little bit of albuterol, CPAP. You know, do get a line in them. Come see us. Yeah. So what do you think's going on with this guy?
He's having a STEMI.
Is he having a stomach?
UTI.
Yeah.
Yeah.
He's probably
No
got
doubt.
a UTI to go with his.
Yeah.
So pneumonia with history of CHF is going to be this guy's diagnosis. Okay, so we've already spoken with about the nitroglycerin, so just, this is just a reminder. And, definitely, CPAP and pneumonia is just fine, okay? And it, in fact, may prevent the patient from being intubated later on, bridge them until we can get them, some fluids. And, the big question is, well, pneumonia with a history of CHF, do you give this guy fluids? And, that's a tricky question that even we grapple with in the emergency department with lots of diagnostics available to us. And you kind of have to tread lightly. All of the hospital and CMS core measures are going to say, give this guy fluids for his pneumonia and sepsis. And then if he becomes too fluid overloaded, then intubate him. So hopefully, if you give him CPAP and then transition to BiPAP and the ED, you can give him some fluids, help his infection, and hopefully bridge him over and prevent him from having to be intubated when he gets too much fluid from his resuscitation from his pneumonia. So, hard case, okay, but more akin to what we actually see on a regular basis. All right, one other of the kind of core cases, and then we'll talk about CPAP and do a run review. So this is a little bit easier. 30-year-old female rather. She's been kind of progressively more short of breath for the last 2 to 3 days. She's got a dry cough, no fevers, doesn't smoke. She has had a URI recently, but next. I'm not going to give you the rest of the history because I think you guys can figure it out. Blood pressure is good. She's a little bit tachycardic, definitely tachypneic, and definitely hypoxic. Okay? She's definitely working. She's been using her albuterol inhalers, and she's finally just not getting any better and had to call the ambulance. She's got, you can hear the wheezing from across the room. You don't need to use your stethoscope rather for this one. Doesn't have any pedal edema. She's otherwise healthy. Okay, so the only history that she's got, which I didn't tell you because it would have made it even too easy, is she's got a history of asthma. Okay, so this is going to be the patient with acute, exacerbation of her asthma and reactive airway disease. Okay, often precipitated by a viral URI or something like that, or a change in the weather, or something like that. Or I ran out of my albuterol. I guess I could have added that to the. Or I'm visiting the dunes, and I've been sitting out by the campfire for the last 2 days. That also is a good one. So what are you going to do for this gal? Good. Okay. Glad you mentioned epi. Next. So definitely albuterol and CPAP for this gal. This is someone who I would open the fluids up, okay, because she's been tachypneic now for a couple days and it's probably pretty dry. Doesn't feel well, so she hasn't been drinking fluids anyways. Fluids have actually been shown to, we always give fluids for asthmatics. It's going to help with their tachycardia and a number of other things. And then, definitely remember, in the very severe asthmatic, the epi is in your respiratory stress protocol. Okay. Kind of keep that in your back pocket. We don't have to use it very often, but definitely I think if you're using the albuterol, you're using the CPAP, especially if you've got a longer transport time, you're going to need to just keep it in your back pocket. Okay? Because asthmatics can die.
Did you say that is this the case that you're going to review or a different case?
No, this is a fake case.
Okay, was anybody here for the ETCO2 class with Dr. Giorgio and Lori? In the case that we reviewed, so it was like this patient basically, and then she maintained, just based on what it says on black and white, I don't know if anyone would give epi to this person yet, but then when the time they got to the ER, and I think they transferred to Arroyo, she was like completely hypoxic, shaking things up, combative.
So end-tidal CO2 can be very helpful in this situation because oxygen level or our pulse ox is not always. So the end-tidal CO2 is going to help you determine how severe the patient is a little bit sooner than their oxygen level. Okay, you guys all know that the pulse oximetry, there's like a minute or two delay, okay, in what the patient actually is experiencing and what your reading is going to be, okay. So someone who's this sick and this potentially, and there's severe potential for severely bad outcome here. And end-tidal CO2, I mean, if this gal's CO2 is starting to shoot up, and she's, starts to retain because her airways are getting so tight, the reason why they become agitated more so is not always the hypoxia, but it's also the CO2, okay, which can be a big problem. So definitely end-tidal CO2 can give you a better indication earlier what direction your patient's going and how sick they are, okay? Because these people can hold on for a long time, and then all of a sudden, boom, they crash.
One of the best lessons was that they used the ETCO2 for this gal, and they were in normal ranges. But so they were, I guess that reduced their level of concern. But then we were talking about how for someone who's been that tachypnic for that long, they shouldn't be normal. And then if you see the trending within like a 6-minute period, they go up, by 10. A factor of 10, and so that that normal number with that really
because they're really tachypnic and they're blowing off, so they should actually have low CO2 levels. Okay, but if you start to see this gal who has like a normal or got a bit of high CO2 level, you're in deep trouble.
So they went on her again actually a couple weeks later, and they gave her the epi really soon because she was in the same condition, and she had a way better outcome.
Interesting.
Yeah.
So.
This lady from Napoma.
And epi, sometimes you have to, think twice about. I don't like giving epi a lot, especially folks who are, over 50, just because it leads to a lot of other issues. But definitely. Is there anyone over 50?
Or at the table
Fred's
back
right
there,
now.
over 50.
But he's very youthful.
But in a lot of these asthmatics, they're younger and they're going to handle a heart rate of 150 for a while, pretty well. Okay, so epi is, and generally, and I don't want to say, never give it for someone over 50. If it's going to save their lives, then I know they might have a non-SC segment elevation MI because of it, but we can deal with that. You can't deal with a dead person because they couldn't breathe. So, yeah. So good discussion on epi. Next. So diagnosis, we all know this, the asthma. Next. All right, so typically younger patients, asthma is diagnosed pretty young. We don't like to diagnose it really in the babies right off, but usually from childhood to young adult, they diagnose it. They have a history, okay? These people know they have asthma, and they've used inhalers before. There usually are specific triggers. I think I mentioned, VRIs, campfires, weather changes, exercise. So I think most people are pretty familiar with a lot of the triggers, and it's kind of interesting to know, what may have triggered them to kind of seal your deal, not confirm this is asthma, not their PE or something. More of a gradual onset usually. Okay, so they've kind of had a little bit of difficulty breathing yesterday, may have used their inhaler a day or two, and then just kind of get worse and worse. And they don't like to come in, and they kind of just they get to the point where like, oh my god, I can't breathe already. So, and then they'll have a cough because they're trying to get a breath and get air, but they're not really doing anything up with the cough. And you get a little bit of hyperinflation in the lungs. Again, they look more elongated in this person. But you do see some lung markings, unlike the COPD person, where the lungs are more black, okay, for lack of a better term. Next.
Just out of curiosity, what's the incidence of people who've had asthma as a young person and a young adult, and then in their later stages of life develop like COPD even without like an emphysema type history?
Usually not. So asthma and COPD are two different disease processes, and the pathology of it, I guess. So asthma, what happens is you get inflammation of the smooth muscles of the airway in the and that smooth muscle hypertrophies, it gets thicker, and it spasms, okay? COPD is where you actually get erosion and breakdown of some of the structure of the lung, okay? So two different disease processes. The older folks who have asthma, so it's hard because a lot of people will tell you, well, I have like asthma/COPD. It's probably a combination of both, and you know, someone who may have had asthma and then you know they decided to smoke, or they're with a smoker, or they just aged and you know got some you know COPD type changes. Okay, so they're different. Strictly speaking, they're different. Okay. Does that answer your question? Okay. So moving on now to CPAP. So what is CPAP? Hopefully you all know that it's continuous positive airway pressure. It's a non-invasive method that we have for assisting and treating patients who have respiratory distress. Why do we use CPAP? There are less complications than trying to intubate a patient, okay? So you're not gonna worry about chipping teeth or you know, causing some sort of airway trauma or anything like that. I didn't list a whole bunch of studies for you. I'm more than welcome to provide you with them if you are interested, but multiple studies have showed a fairly significant reduction in morbidity and mortality with the use of CPAP, non-invasive CPAP and BiPAP. Okay, and it's shown also in those studies that it reduces the length of stays in the ICU, okay? And it reduces admission to the ICU in general. Okay, and it's more cost effective. Always the hot button. So what does CPAP do? So you're providing continuous pressure to the airway to keep these little, you've seen like a, you know, like anatomy textbook, they look like little grapes, okay, little round alveoli in the lungs. They collapse when there's fluid around them, and so the positive pressure of the CPAP helps open those up, and when you open those up, it better allows gas change to occur because of the increased surface area. And also that positive pressure, just because of the gradient, it helps move fluid, helps push fluid out of the lungs, and it stops the fluid from moving into the lungs, okay? And so it keeps that same pressure when the patient is taking a breath and also exhaling. So yeah, like I mentioned before, it kind of stents those small little airways open, and also, like I mentioned, it improves the delivery of your albuterol and your bronchodilators as much as 80%. That's a pretty significant improvement in delivery. Okay. Does that all make sense to everybody? I know it's a little bit hard to explain. The lung is obviously very complex, and this isn't a physiology lecture, but hopefully that gives you enough idea to kind of have in your mind of why we do it and how it works. So, okay. Next. And this is kind of a review of what we've spoken of already, but just to reiterate, so great to use CPAP for pulmonary edema and CHF. Asthma and reactive airway disease is just kind of the general term for asthma, like I explained with the mechanism of asthma before, those smooth muscle spasms and contracts. Okay, it's a good piece for COPD also. We already talked about pneumonia. It's okay for pneumonia. It's actually good for pneumonia. Okay, it can help prevent intubation down the line. So the other thing that I didn't have a specific case for this, is near drowning. Okay, and this, so when we go back up to pulmonary edema, you can have other reasons for pulmonary edema besides congestive heart failure. Have you ever given Narcan to a heroin overdose and then all of a sudden their SATs are 70? So a lot of times when you give Narcan to a heroin overdose, they develop acute pulmonary edema. And this is a situation where now that they've woken up, since you've given them Narcan, you can slap some CPAP on them. Okay, so it's something to think about. We don't see it very often. We're seeing a little bit more heroin, so we might be seeing more of it in the future. But just something to think about. Other causes of pulmonary edema you're drowning the narcotics, that type of thing.
Why does that happen?
Tell her about our lung cancer.
I've read a couple different things about why that happens, and it doesn't sound like people know exactly why it happens, but it's something, and it's usually like right around the time that you give the Narcan. Yeah.
Mm.
So I have not read a conclusive explanation of really why it happens, but it's not uncommon.
Just as another aside, Dr. Giorgio last week was talking about, I don't know if you guys remember, probably about 6-8 months ago, I sent out a thing from Dr. Renee from the CDC describing the fentanyl, the synthetic fentanyl with the heroin that's getting mixed. And
Crazy
they,
clown stuff.
yeah, sorry?
Is it the crazy clown stuff?
Well, I don't know, I forget what it's called, but it's essentially, it's like a crazy dose of heroin that's being,
They're mixing it with fentanyl.
Yeah.
That's what, is that what Philip Seymour Hoffman?
Yeah.
yes,
He had
yeah.
fentanyl also.
So like tons of it on the East Coast, and I guess now they are starting to see some, it's moving west, and I think they've had some cases in California, but I just actually had a report in Chicago. There's like, you know.
Yeah, I mean, I think we always kind of see this tide with the drugs. You know, heroin was real popular for a while, and then it kind of died down. And then I feel like, you know, in the last, I feel like we're seeing or going to be seeing a resurgence of it. So just something to keep in mind, especially when you get ready to shoot the Narcan. Like,
Yeah.
oh no, their stats are eating now.
Have you actually seen that, around this area, where they've developed the pulmonary edema?
I have seen it, yeah. I feel like, I don't know, you guys know the populations at French and AG are different. I always feel like, especially when I worked a lot of nights at EG, it was like overdose central. I've seen some of the craziest overdoses down there. And it's always at night, you know, we've had I swallowed a baggie of cocaine, you know, when the cop pulled me over and it was in my soda, and we couldn't figure out why the patient was in a sine wave. I mean, basically his EKG was in a sine wave for like an hour, and it was like a peri code, and it was like, well, finally you told me, oh, well, I swallowed a bag of cocaine. I was like, oh, 6. So, and like crazy, Benadryl overdoses, requiring like the entire county supply of bicarb and heroin. We've seen some narcotic overdoses down there, and you just look at you get a chest X-ray on this like 20-year-old, and you're like, wow, it looks like the one I showed you of the pulmonary edema with the it's basically whited out bilaterally. So I have seen it. I probably see it, I want to say like 50% on probably like half of my heroin and narcotic overdoses. I see it. Yeah. Plus, then you never know if they've aspirated while they were unconscious, and like other things can happen. So it's not that uncommon in heroin overdoses, and that's why I mention it, because you guys may not see it very often, especially since we probably see it more in the ED than you guys see it pre-hospital. But that's why I mention it, because it can be any cause of pulmonary edema. If you've got fluid in your lungs, or if it sounds like the patient might have fluid in your lungs, or heck, if they've got a PE and can't breathe and they're hypoxic, just let the backup on. It's not gonna hurt. We didn't talk about PE either, but obviously there are lots of other causes of respiratory stress, and that's why our county policy isn't perfect, for lack of a better word, because it focuses on just 3 diagnoses, but there are tons of causes of respiratory stress, obviously. So, yeah. Okay. Next. So when shouldn't you use CPAP? All right. So if the patient is unconscious, so let me have a few words about this. So the main concern when someone's unconscious is you don't want them to vomit into the CPAP mask, okay? Because we use positive pressure, the BiPAP we use in the ED, we use on patients who aren't all completely with it. And basically, if the patient's with it enough that if they vomit, they can rip their mask off, it's okay. Or if you think someone's kind of like, might not be like super with it, don't strap it on it, just hold it on them. Okay, that's another option. Obviously, if they're unable to protect their airway, they need to be intubated. Respiratory arrest, same thing. Vomiting, for what I just explained. If obviously, facial trauma, they've, been in a MVC, or if it's a, penetrating wound, some sort of penetrating wound to the face, and you can't get a seal, obviously you can't use it. And, penetrating chest trauma, that's really not indicated also. Need for vaginal mass or intubation, that's self-explanatory. And then hypotension also, and go ahead and go to the next slide. So the reason for this is that a lot of times with the CPAP folks, you'll see a drop of blood pressure after you put it on, and that's because of the physiology of it. So what happens is, because of the CPAP causes an increase in the intrathoracic pressure, and that increase in intrathoracic pressure causes decreased filling of the heart, okay? And so basically you're gonna get decreased cardiac output and thus decreased blood pressure, okay? So you can use CPAP on someone who's hypotensive, but you need to be very careful because it likely will drop their blood pressure lower, okay? And we're actually gonna talk about that in the REM review I have, which we'll bring up that point a bit more, okay? Because the patient was hypotensive. Alright, so.
I would say that just as, I think everybody knows this, but if you have someone who's like borderline hypotensive or hypotensive technically or altered, like, your chart says that they don't have a GCS at 15, but you still feel like CPAP would be a benefit.
Just call and
Yeah,
ask
you have a resource to call and get orders
Absolutely.
for.
Absolutely. So go ahead and go to the next slide. So this is a case that, again, was forwarded to me by one of you guys, and it was just last month as a good respiratory distress case. And I think it's a really, really good case because it brings up a couple issues and a couple, again, it's not one of those straightforward ones like I presented, it's one of the more complex ones. So I think that it will be hopefully promote some good discussion. So this was a 59-year-old male. The call came in for chest pain and shortness of breath that had been worsening for most of the morning, so for about 3 hours or so. The patient was reportedly able to speak only 1 to 2 word statements and was able to explain that he felt starved of air. And this is all straight out of your PCR. So his past medical history included he had a paralyzed epiglottis from I believe some sort of like a laryngeal nerve injury or something like that. Traumatic brain injury, COPD, and he and the family, or the family, I guess, the sister had reported that he had been discharged from the hospital 3 to 4 days earlier with pneumonia and was currently on Levaquin. So next slide. Interestingly, you know how time is always like 3 to 4 days, 3 to 4 weeks, 3 to 4 beers, 3 to 4 time changes for everybody. So it was interesting. So it was actually like 3 to 4 weeks that the patient had been discharged. So I don't know why he was still on Levaquin, but anyhow, that's neither here nor there. So he's taking albuterol, Lamictal, Norco, antidepressant, losartan, Flovent, a bunch of psych meds. Still on Levaquin and Tegretol. I'm assuming he's probably got seizures from his traumatic brain injury. So, and interestingly, also I'll throw in this little aside here. It was also in the narrative in the PCR. So I guess the sister thought that the patient was having an allergic reaction to the Levaquin. So after his dose that day, had just thrown it away. I know, that's just how people think. So he's hypotensive, is 80/48, pulse 94, respirations are 26. So pretty sick guy. Sats were 67%. I couldn't tell, because he is on home oxygen, I couldn't tell if this was on his home oxygen or room air, but basically 67% is poor. It's not good no matter what. So, according to the physical exam, so he doesn't have any oral cyanosis. He's got bronchi bilaterally with diminished breath sounds on the left, but he doesn't have any DVD, doesn't have any pedal edema, and it was documented that he didn't have any tracheal deviation or paranasal chest wall movement. So that's good. Someone who's hypotensive and more acutely short of breath, you want to think about has this COPD patient, dropped a lung and had a spontaneous pneumothorax. Okay, that's a situation, if you did think that they had a pneumothorax, you would not want to put them on CPAP because of the pressure and that type of thing. Okay, so that's another thing that I didn't mention, but good that it came up here. Next. So, what do you do for this guy? So he's hypotensive, his pressure's in the toilet, his pressure's 80, his sats are even lower, he can't breathe, and he's got all muscle problems. This is what he's done.
You went to the hospital.
Everything
All
in
in
the
the
hospital.
hospital.
So, he had a non-rebreather mask put on, and he felt a little bit better, but his sats were still very low. A saline lock was established, and a 12 lead was performed, which did not show anything acute. Are you going to CPAP this guy? You give him any albuterol?
That's good.
Pressure's 80.
Oh, maybe. I'll call the docs.
Good, good, okay. Next slide. Yeah, so, the two questions are, do you CPAP this guy, his pressure's 80, and, do you give him any nebulizer? Is he on albuterol at home, he's short of breath, he's got a history of COPD?
Are you worried about having the paralyzed epiglottis, with deposit pressure getting like gastric insufflation?
That's a good question, and I would say, it's probably not going to be a bad thing. Yeah. So continue on. So, the medic made base, and specifically asked, I think this patient would benefit from CPAP. What do you think? And the base physician asked again what the vital signs were, and was told that the pressure was 80/40, and did not feel comfortable with the medic starting CPAP with a pressure of 80/40, and recommended a fluid challenge. All right, so next. So with fluids, I think the patient only got a couple hundred cc's in the field, pretty short transport time, and the patient's pressure did come up. It was like 95 or so when the patient arrived in the ED. Okay. Interestingly, no nebulizers were given on this case, so that's kind of that's debatable. I mean, I think in this situation, I probably would have given some nebulizers, with his mask. Okay. So what happened to this guy? So I know that a lot of times, you drop the patients off, and some of you come back and ask, and sometimes we look for you guys and tell you, but you don't always know. We get busy and things happen. So it's always, I think, kind of nice to know, what happens to patients and where they go and how they do. So this guy came into the ED. He was put on BiPAP, so I was the base physician. I'll throw myself under the bus right there. And the medic still teases me that the patient was put on BiPAP as soon as they got to the ED. His pressure was better then. And it's just hard, when you're, I would feel horrible if I told the medic to put the patient on BiPAP and they became hypotensive and coded, So, if I put the patient on BiPAP myself after seeing the patient and they become hypotensive and coded, then I am responsible. That's more my issue, but I would feel bad if I told someone to do it and I hadn't been able to see the patient and that type of thing. So he had, sorry about the typo here, so he had multiple long-term nebulizers and breathing treatments, and was put on BiPAP and actually did very well. His sats came up to around 100%. He got a total of 2 liters of fluid, IV, pretty quickly in the ED, and his pressures came up above 100. He received antibiotics because his chest x-ray showed basically bilateral infiltrates. It looked like he might have had a little bit of fluid and edema developing, but essentially he had bilateral infiltrates consistent with pneumonia. So he was giving antibiotics, and he was also given salbutamol. So we give, a lot of times we'll give, you guys know that we give steroids for, you know, COPD and asthma exacerbations and that type of thing. So this guy was given salbutamol because of that. Okay. So
Rachel, you said in the field you have given him a nebulizer, but you didn't do that in the ER.
he did. He got multiple long-term notes.
Oh, that's right, I forgot
Yeah,
that
sorry,
news
my
was
typo.
there. Yeah, I'm sorry.
Yeah, exactly.
Okay.
So it really helped this guy. And he, so someone who's on alcohol. Yeah. he's
So-
on-
And that if you're suspecting pneumonia, but you're not hearing any wheezes, then obviously that's something that you guys are totally good with us. They're gonna get that type of treatment in the ED, so why not call and say, hey,
Yeah. I mean, you don't specifically hear wheezes, but they're just kind of sound junky, and you think they're, you know, they may have aspirated or have pneumonia, and they feel hot. Then you give them a nebulizer. Yeah, it's gonna help open them up and just help symptomatically, especially if they're really damaged. Yeah. Plus, it just makes you feel like you're helping someone and doing something for them. It makes them feel like you're doing something for them instead of just sitting there like looking at them breathe 25 times a minute and be like, I don't know what else to do for you.
So you're saying there's value in the placebo effect?
There is value in the placebo effect, yes.
So at the next meeting, are you gonna add ipratropium to our med list?
I have battled the respiratory distress protocol for quite some time and have not made any headway. So I don't
You just
know.
need the master's level of thinking.
I don't know that the program. I don't know that I'm ready to readdress at the county level. I mean, I've tried, so haven't gotten very far. We've got other fish to fry now.
What,
But we'll come around to that maybe.
I'm just curious, because you've mentioned it a couple of times, if you were making or queen and they came to you and said, write a new protocol, how would you structure it?
Well, it would be more general. Okay, so I have actually,
You have done
I have a copy of the protocol right here, and I mean, so basically, it's basically, you know, asthma, pulmonary edema, and COPD. Like those are the 3 prongs of the protocol, and I mean that's silly. I mean, so I would say, you know, I mean, you kind of got to look at symptoms, and I mean, almost everyone's going to benefit from albuterol, you know. So they're like, you know, wheezes, bronchi, you know, you probably want to do, you know, CPAP and, you know, saline lock and albuterol. And, you know, if they're aroused and, you know, pulmonary edema, then, you know, consider nitro, you know, I mean, basically CPAP, consider nitro, maybe not albuterol. You know, I mean, I just think it needs to be more generalized because again, you can't make these diagnoses in the field. So,
yeah, this is a
I
constant
mean, they certainly
QI
could be
question.
pulmonary edema, but, well, what about their pneumonia? So that's my biggest beef with it. And, I mean, we've gone, I mean, Groves knows, we've gone around and around and around.
I would say that I would guess that the reasoning for this is that when you don't have that specific diagnosis for whatever patient you're treating, yet they clinically meet the signs for this or some other general, you know, respiratory emergency, that the drive home point is that to call the doctors and say, I have this is what I'm seeing clinically, I'd like to do this, even though it's outside that protocol, and get a more Mother May I approach.
I mean, albuterol is pretty benign. I mean, in a few situations, in the 5-year-old ladies who have a history of paroxysmal AFibs, you know, sometimes you can, tip them over into AFib or trigger that again. If they're already in AFib and they're really tachycardic, you know, sometimes it's not good. But I mean, in general, albuterol is a pretty benign drug, and I mean, we give lots of it in the ED. You know, like this guy probably had like 2 or 3 long-term nebs, and they sit there for like hours on them. He probably was on albuterol for like the first 3 hours he got to the ED. You know, and so you know, albuterol is pretty benign, and you know, CPAP is pretty benign. You can always take it off. You know, if the patient can't tolerate it, or if they feel like they get worse or too hypertensive, something else isn't quite right, then you can take it off. So it's hard, I think, to really go wrong with those 2. You know, nitro you've got to think a little bit more about, just because the things that we talked about with it could be diagnosis and wrapping up pressure too much, but, I mean, otherwise, I mean, I think you guys kind of get the gist of, you know, based on all the cases and the discussion we've had, right? Yeah, okay. So this guy ended up, so his final ED diagnosis, so he was transferred, he was admitted to the intensive care unit, and he actually improved quite a bit in the emergency department and did not have to be intubated. He was diagnosed with respiratory failure, bilateral pneumonia, sepsis, and then possible MI was one of his final ED diagnoses. So what happened was he had a troponin, which was a little bit borderline, I think. And I think what happened was that he, you know, sometimes you can get heart strain from respiratory failure, and a lot of times we'll see bump troponins. So I don't think that, when I looked at his discharge summary from, he was in the hospital for like a long time, probably like almost 10 days or 2 weeks. So he didn't have MI on his discharge diagnosis, so I think that was just probably from, you know, some heart strain. So he had a fairly rocky course. I mean, he was stabilized in the ED, and then his ICU course was a little bit rocky. He did end up getting intubated and had a bronch because he had some mucus plugging, and they thought that the pneumonia was probably aspiration, okay, because he had a, you know, I think I forgot to mention this in the history, and I probably should have. He had a pig tube, okay, and so we aspirated and you know, had some mucus plugging, ended up having to have a bronch, intubated, but you know, definitely, you know, not having to intubate him as soon as he got to the you know, to the ED was a good thing for this guy. So you know, you know, should he have had CPAP in the field? You know, it's hard to say. I mean, hindsight's 20/20. You know, would he have gotten enough fluids to counteract his hypotension that the CPAP was going to cause, you know, cause more of? Again, it's that fine line. And looking at this case again, you know, especially with me being the physician, that you always try to, like, you know, Monday morning quarterback yourself. And I don't think that I would have, you know, CPAP this guy, you know, still with a pressure of 80. I mean, if you had a longer retention time, given him a fluid bolus, his pressure came up to 95. I think then I probably would have said, okay, go ahead with the CPAP and continue fluids. But I think they transported him pretty quickly, and because he was code 3 and pretty close to AG. So,
Rachel, what's the onset of just the building of that intrathoracic pressure? I mean, is that like in it?
I mean, it's pretty quick.
Okay.
Yeah, I mean, because, I mean, that's another thing with, you have control over some of the settings, and that's an advantage of starting lower. Okay, you start with a lower setting, and see, you know, how they do, how their pressure does, and then kind of gradually increasing it and see how they tolerate it and how the pressure tolerates it. Yeah, because you're gonna get it right away because it's immediate positive pressure. So, yeah.
I had a case last week where we used CPAP, and it kind of surprised me that we did use it, and here's the scenario. We walk in, this gentleman's about 48 years old. He's semi-fowler, complaining of shortness of breath, explained that he'd never been short of breath in his life, so he gave it an 8 on a scale of 1 to 10. No chest pain, lungs are clear and equal, he feels febrile, but he's got a room air stat of 74, 76. So I immediately start feeling his hands. Is he cold? No. He's warm. He feels like he has a fever. I'm still looking at the pulse ox.
Yeah.
I stick it on my finger, it goes to 97.
Yeah.
So I have to believe that he's in the high 70s.
That's the thing. That's why the respiratory stress protocol is like,
Now,
well, where does that guy fall,
to
right?
compound it, he's hypotensive. Our first reading was 80 over something. We get him in the unit, and we saw 106 over something, then the next reading is 90, and the next one is 80, and it's kind of bouncing all over the place.
Yeah.
So we call the ED, and it's Dr. Griffin on duty, and he asked us to use CPAP. So we just wanted to confirm that we're going to use CPAP on a hypotensive patient. He said, go ahead. And a remarkable improvement with this gentleman. So.
Well, I'm glad you shared that case, because I think that's a good case, and I think, I mean, he was obviously in distress. And did you guys give him fluids also? Or?
No, but his history is pancreatic cancer.
Interesting.
And when I left the ED, so I don't know the end diagnosis, but when I left the ED, they hadn't taken a rectal temp on this guy because they were afraid of his immunocompromise. So I don't know the endpoint, what happened.
Yeah, I mean, and I think, you know, with the pressure a little bit better than 80, you know, than 190, I mean, I'm a little bit more comfortable with that than, I mean, I think 80.
Because it's borderline.
The 80, the next pressure is gonna be 60.
Yeah. I mean, he still remained, as I recall,
Yeah.
hypotensive,
Right, right.
but he got considerable improvement in his end tidal and
Good,
his rolling
good.
factor. So.
Well, I think, I mean, that's a really good case to share, and it just goes to prove that, you know, even when you don't know exactly what's going on, if they're really in distress, you can give them some CPAP, and it can be.
5-1, 10%. Hi, Fred.
Low vinegary.
Somebody will play.
Yeah.
Does anybody else have any other questions at all, or comments, or CPAP cases they wanna share, or talk about, or have questions about, or?
So, I think I learned something. You said when the alveoli collapse, it's because the fluid is around them. It's
Mhm.
not actually fluid getting into the alveoli themselves.
There's both.
Both.
Yeah, so there's fluid on the outside of the alveoli, and there's fluid inside, okay? So the positive pressure helps push that inside fluid out and helps prevent the outside fluid from coming back in. So it works both ways, yeah, so there's inside fluid and outside fluid. Yep. Good question. I think you learned something.
I learned something.
How did that feel though, by the way? You had a headache? That's the story. He just forgot his kid.
It's gonna be more like your CHF and pneumonia, okay, that are gonna have like the collapsed alveoli. But, you know, you can get it in COPD too. I mean, COPD, you're just kind of basically stenting the airways open, okay? But you're gonna get more of that collapse if there's, you know, pneumonia or CHF, yeah, or some other type of pulmonary edema. Yeah. With COPD, you're gonna help, you know, just improve the oxygen gradient, okay?
The shredder.